webinar. Today we are pleased to welcome Dr. Andy Pomerantz. Dr. Pomerantz is the VA's National Mental Health Director for Integrated Services. He's the Associate Professor of Psychiatry at the School of Medicine at Dartmouth and a current member of the CFHA Board of Directors. He has been a primary care physician, consultation and geriatric psychiatrist, and he was the Chief of Mental Health at the VA in Vermont for nearly 20 years. He's received many local and national awards for his work in integrating health and primary care, mental health and primary care, and other programs, and he is a Distinguished Life Fellow at the American Psychiatric Association. Dr. Pomerantz today will be talking with us about integrating primary care, bringing mental health care to those who need it, with a special emphasis in forgetting the financing. It doesn't mean a thing unless the patient gets the care. And I will now pass the screen to Dr. Pomerantz.
Okay, thank you, Polly. If things are working as they should, people should see a blue screen about integrated primary care. If not, then just let me know and we'll try to figure it out. I really appreciate this opportunity, and we're talking initially about just how to integrate primary care and mental health. One of the things that's been of great concern to me and a lot of others is that so much of the discussion is just about getting paid for providing mental health services, and not so much focus on some of the more clinical and operational details about what happens when you really are getting paid. And I've seen a number of instances where mental health services have been brought into primary care and paid for, but have really not made any great contribution to the care. I'll tell a quick story about my early days as a primary care physician here in a small town in Vermont when I was struggling. I was fresh out of training. I was struggling with some of the behavioral influences on the health of my patients, and community mental health services were a new thing at the time. And so I invited the Community Mental Health Center, which was about 25 miles away, to send the therapist into my practice. Come join us here, and maybe we can get some help. And so somebody came over, and the first person I referred to him was a fellow by the name of Jim, who was having a number of different struggles. He was a little bit lost, didn't know what he was wanting to do with himself. He was smoking too much, and a few other behavioral problems, a little depressed from time to time. So Jim began seeing the therapist, and of course the therapist couldn't tell me anything about what was going on. It was all very private, but I started hearing from Jim. I said, you know, this isn't, why'd you send me to this guy? He just wants to talk about my mother. Then one evening, he came on Monday evenings. I came in for my Monday evening office hours, and Jim came in shortly after that with an ice cream cone, and the therapist said to me, well, what do you think about someone who comes to his therapist's appointment licking an ice cream cone? And yeah, this was summer. I said, well, maybe because it's hot outside and it tastes good. He shook his head, went into the room with Jim, and that was the last time Jim ever saw him again. Jim came back to see me and said, look, the guy just wanted to talk about my mother. He wouldn't, had all these other things. So as a PCP doing what I could as the friendly family physician, we talked a little bit, my not knowing much about mental health. Jim eventually became a very successful businessman and philanthropist. Never was willing to go to mental health services again. And it's fairly common, what we see is that when we just do what we always do in mental health, or what we're accustomed to doing, very often it doesn't meet the needs that our patients are coming to see us for. I'm going to start with a graph here, if my screen will respond. There we go. This is a slide from a paper that came out in the New England Journal of Medicine in 2007 about improving the health of the American people. I think it pretty well speaks for itself when you think about what are the real determinants of health. I realize this chart is about mortality and not about health. And I'd be the first to agree that they are two very different things. But I use it because it's much more measurable than health. There's no argument when you use mortality as a variable. Don't argue whether someone's healthy or not, or dead or not, the way you argue about whether they're healthy or not. But really, you can see the preponderance of influence on health in this chart is on the psychosocial and behavioral factors. What we know, all other things being equal, a mental disorder complicating, comorbid with other disorders, leads to poorer health outcome. Costs are higher, mortality is higher, quality of life is higher. And one of the things we often don't measure very well when we're confining ourselves to looking at costs in healthcare is what are the other costs to society? And there are a lot of other costs, and that's a whole nother talk we could be doing. But we do see when we treat, and again, our poster child for integrated care is often depression, mainly because it's so prevalent, because there are good treatments, and there's a great evidence base on what you can do that's effective in primary care. But all these things you see listed here are what it's all about. And certainly when you think about resilient families and communities doing a better job of child rearing, being better at work, more productive, you can begin to see some of those other costs to society that are impacted but very difficult to measure when we deliver mental health treatments where they're needed. There's often an argument, people talk about the word cost effectiveness. What do you really mean by that? And what I mean by that is that treatment, the value of the treatment, the outcome is worth the cost. Unfortunately, very often cost effectiveness is used to refer to cost offset. For reasons that are unknown to me, many folks looking at healthcare financing, or just looking at healthcare in general, have a belief that treatment of mental disorders is something that should save money. I don't know any other branch of healthcare that is expected to save money on the treatment itself. We may, and we're showing more and more how there are many downstream costs of healthcare that are probably affected, but you don't see them right away. So where are we now? This is a summary from the National Alliance for the Mentally Ill that basically points out the fact that comorbidity is the name of the game. Most people have both mental disorder and other non-mental disorders. So many of those with medical conditions have mental health problems, and for the most part, these people present in primary care, and for the most part, they're untreated or undertreated. That's why primary care has long been known, in paper back, 20 years ago now, described primary care as the de facto mental health system. So how does that work? Primary care is our mental health system. Follow-up studies have demonstrated a pretty low number of people, just again, focused on depression alone, pretty low percentage actually receive adequate treatment for depression. Are we making any progress? No. I mean, there's no, over the years, the studies of where mental disorders are treated, where behavioral conditions are treated, have not shown any real movement here. Integration is not a new thing. This began when David Satcher was Surgeon General during the George W. Bush era. Institute of Medicine followed with their calls and their quality chasm reports. The New Freedom Commission, which was another Bush-appointed commission that pointed out the need for integrating mental health services, integrating as well substance abuse services with mental health services. I'm spoiled because I work in a system, which I'll tell you a little bit about in a few minutes, where mental health services and mental health services in general are not separate, but I know in a lot of places they are. And patients voting with their feet. What I mean by that is the vast number of patients who, if they are referred out of primary care to specialized mental health care, simply don't go. They refuse to go. Some will go once and not go back. Just the follow-up is exceedingly depressing. So here are the reasons that so many are advocating for integration. Number one, it improves overall health. We know that. Screening has always been an issue. We know that screening for anything is often worse than not screening at all, unless it is followed with a clear clinical pathway. It's one of the things we're finding in integrated care systems, that if there's a pathway, if there's something you can do with a positive screen, primary care is much more willing to do the screen. But otherwise, what do? What does a primary care provider or team do when they have somebody who's screened positive for a mental disorder and no resources that they can take? We've often heard, and we're hearing more and more, particularly whenever there's a violent act in society, about the mental health crisis. I'm a psychiatrist, so I often hear from my colleagues about we just need more psychiatrists. What is happening is there's increasing demand as more and more mental disorders are recognized, and decreasing supply. The more people you screen, the more the demand, and if you have a fixed number of providers or declining level of providers, then you're going to have that imbalance. I've talked with a lot of people, looked into the literature last year about all of the different ideas about what could be done to maybe bring some more people into psychiatry and other mental health professions. Lots of ideas. This comment about return to the good old days, that's one I hear a lot from psychiatrists, which is that, forget all this stuff about using us for just medication management and biological interventions, and let us just be the whole mental health clinician. In other words, what this always translates to is let's find a way to spend more money. So then well, just how much is it going to cost? Here's where we start getting into a little bit of my concern about the focus on financing. How much will it really take us to, how much does it really need to do all the things that we want to do if we do them the way we have always done them? And that's an important point. And this discussion is going on outside. It's not specific to mental health. It's out there in many fields. There are a lot of things that we know we need more money for. But I don't. Maybe you guys have an idea where we're going to get it. I just don't see in our current climate or the near future climate that there's going to be a lot of interest in spending a lot more money on health care. Or on mental health care. In many systems, mental health care is seen as discretionary. In times of feast, there are more mental health resources. In times of famine, like a lot of other human services, they get cut. So instead of looking at having not enough resources, not enough supply to meet the demand, maybe a different way to approach it is to take a different look and say, well, what is really the problem? Is it not enough providers, or is it not enough access? I've asterisked access just to point out that we often forget that access is not just the objective measurement we make of how long until the person can get to an appointment. Access is also very subjective. There are an awful lot of patient-level factors in access. Yes, there's a psychiatrist, there's a psychologist, a clinical social worker, a psych nurse, physician assistant. They're ready. They can see you right now. Yes, they're across town, they're in another building, so on. But if you really want to go, you can get there. Access is perceived differently by patients than it is by those of us who design healthcare systems. But for me, as you know, I don't even have to tell you from what I've been saying that I think the problem is number two here. The problem with access. Demand is growing. It's going to keep growing. But we just, in our current systems, the way we're designed, we just don't have enough good access. So in part of my look, when I was looking into the shortage of mental health professionals last year, I came across a paper that was written a very long time ago, quarter of a century ago. This was around the time after I had moved out of primary care, went into psychiatry. This was published almost exactly the time I was getting out of my psychiatry residency. There was a great deal of concern among some people, particularly those who, Joel Yeager, who wrote this paper, that maybe we're training too many psychiatrists. There are going to be too many, and this is most of what is written here in this paragraph has really come true. I think the part that has not come to be has been the expected excess number of primary care physicians, because we know also that there is a shortage of primary care physicians, and a lot of the patient-centered medical home models designed around team-based care, which have been demonstrated to be more effective than solo providers. A lot of those models are learning ways to have primary care providers just do what only they can do while others do what they can do. Similar is what we may need to be doing and what this paper suggested in mental health care.
Dr. Pomerantz, we've had a couple of individuals say they can't quite hear you. Would you mind speaking just a bit louder?
Okay, I will get closer to my screen. Is that any better? Well, we'll find out. If it's not better, just let me know, Polly.
Perfect, thanks.
Okay. Here's a paper, commissioned study by the Agency for Healthcare Research and Quality that made a pretty strong statement. The medical home is not going to be successful unless we start shifting a lot of the responsibility for mental health care from specialty mental health into primary care. They also didn't stop there with this comment, which I think many of you who are listening have probably encountered, those of you who have already taken the integrated care Kool-Aid, that many people in specialty mental health care really oppose this idea. There's a particular model of care. I was actually answering a question from somebody in another part of the country this morning within the VA system who was making a pretty strong statement that delivering brief care within primary care was not ethical, and that we shouldn't be doing it. So there is an awful lot of resistance, based on very fine thinking individuals who were trained in a particular model of care and have concerns about the kind of care that we provide in integrated care. One of the things we've begun to find, we're beginning to generate an awful lot of findings in the Veterans Health Administration. I'll get to a little bit more of this as we go, but here's some things that we've found already. We have our integrated care has been going on in the VA for quite some time in a lot of different places in the last 20 years, but in a very organized, formal way since 2007. And we have an ongoing national evaluation that has begun to demonstrate some pretty significant findings. And I think you can see them right here. I'll talk a little bit more about that as we go along. One of the first shifts one has to make in thinking about integrated care is to first understand that the medical model, which means many things to many people, is not just about giving people pills for symptoms. The medical model has a lot to teach, and what it teaches us, what has always taught me right from the very beginning, certainly as a primary care physician, is that not all problems are complex. Not all problems need to start with the same level of intensity of assessment and treatment, which is what we often do in specialty mental health care. We often approach any patient as though they have a complex disorder. We inquire into every aspect of their life, try to know everything we possibly can, when maybe they've come in with a fairly simple and straightforward problem. So a lot of our work in designing integrated care systems and working in them is to try to sort out, well, what can be dealt with in a brief problem-focused way, and what really needs the more intensive level of care and treatment. One of the things we know from a number of studies is that most people coming for referred for mental health care either show up for one session and not come back, or do not show up at all. Between those two, that's the majority. More than half of patients referred for mental health care never show up. And when you stop to think a little bit about that, provider sitting in an office waiting for a patient to show up means that 2 patients have not gotten treatment. And for a patient who comes just once and doesn't come back, that makes 3 patients have not gotten treatment in that one block of time. So we really need to focus more on what kinds of services we can deliver by healthcare team with a number of different individuals working together in a way that's described here in this next slide from again from the ARC, that really addresses directly, what really is primary care mental health integration, what is this team, what do you do, and it's really, they describe here, a practice team of clinicians, and it's not just physicians, it's a wide range of clinicians working in the primary care environment addressing mental health needs. We go back a little bit. I often think that we're kind of getting back to the future because really when you go back to the beginning of civilization, or at least as we know civilization, starting with the shamans and others of that particular mindset, healthcare really was integrated. The shamans, for instance, often saw illness in individual really as a reflection of something in the community and addressed the whole community. They didn't separate things out the way we have for the last 1,000 years or 2. More recently, there was an important chart review study, a study in the New England Journal that I read back 20-something years ago, that patients with somatization disorder, where all that happened was a psychiatrist read through the chart, made treatment recommendations to the primary care clinicians, and outcomes improved and cost was lower. Following that came the care management studies. Many of you are probably familiar with the impact model, which is one of the leading studies. There were others, the RESPECT 3-component model of care, and Prospect and a few others. And those studies were really based on using a nurse care manager to provide follow-up for patients being treated for depression. The earliest studies, it was as simple as all that. A nurse following an algorithm, prescribed protocols after a patient would be started on an antidepressant in primary care, would call the patient regularly, frequent intervals, do a PHQ-9, assess symptoms, assess medication side effects, do a few interventions over the phone, little behavioral activation, some education, and stay connected with the consulting psychiatrist as well as the PCP, and make recommendations to the PCPs. This kind of collaborative care really kind of got the ball rolling 20 years ago. Another thing that was going on in the 1990s was this was a first era, or one of many eras actually, but it was the first in more modern times where healthcare was going to be redesigned and primary care was going to be the center of all healthcare. And at the time, a lot of mental health providers, like the one I had in my practice in the 1970s, started co-locating in primary care, and it just did not work. Again, because they just did typical mental health practice that's very time-consuming, that provided a level of care that most of the patients in primary care who had fairly simple, straightforward needs didn't really need. Within the VA, we took the co-location model along with went beyond co-locations, changed the style of practice, made it more collaborative, combined it with the care management that I just described, and made that policy in 2007. Since then, the VA has gone on to develop its own patient-centered medical home known as the Patient-Aligned Care Team. So I'll go into a little bit of this. Some of you already know a lot about the VA. Some know nothing. One thing that often comes as a surprise to people is that the Department of Veterans Affairs is not part of the military. The Department of Defense has its own healthcare system, and the VA has its own healthcare system. Our mission is focused on people who have been in the military. Although there are, increasing places and times where the two are combined together, that's our mission in Veterans Health Administration. VA has benefits. That's the part that determines disability and provides various financial and other benefits to veterans. The National Cemetery Administration, which runs the cemeteries, that's the only arm of VA that I think doesn't get featured in the news stories on a regular basis. And then there's us, the VHA, which includes the readjustment counseling services known as the vet centers, and so on. So that's about as far as I'm going to go into the structure of VA. We are funded primarily through congressional appropriation. Every year we have a budget, and we have to work within the confines of that budget. We are divided into 22 regional networks, and reimbursement is based on the number of people who are receiving care. And there's a scale of reimbursement based on your most complex condition, so that somebody with catastrophic multi-system disease, maybe a double amputee with blindness, etc., is going to be in the highest reimbursement category. Somewhere down the line are people with severe mental illness, schizophrenia, and so on, who are needing a lot of resources, down to the basic level of care, a young, healthy person, the kind of person that most of the private health insurance plans are looking for. And even now, more globally, healthcare as it's now evolving is looking to enroll more of those folks. We do get some third-party reimbursement, but that's not a significant part of the budget. When VA shifted to the patient-centered medical home model, here are the statements about what it is supposed to be. You talk to most providers anywhere, and they say, "Well, I've always been patient-centered." But this is, really an attempt by VA and as well as other entities throughout the country, to develop care that is really focused on the needs and goals of the person sitting across the chair, which may not have anything to do with reducing their psychological symptoms, may have everything to do with just helping them to become more productive members of their family and society. This is a diagram of how the VA's patient-centered medical home is structured. The work of Bodenheimer kind of guided and informed the development of the PACT in VA, with a core teamlet, which consists of a primary care provider, a RN care manager, an LVN or other clinical associate, and a clerical person. Then there may be some others, like there may be trainees, residents, fellows, and so on in there. Beyond the teamlets, a number of teamlets together form a team, and they have expanded providers within that team. That's where you will find clinical dietetics, clinical pharmacy, social work case managers, as well as the integrated mental health providers. I'll skip over this about interdisciplinary team. Here's another way of viewing the primary, secondary, and tertiary care, and indebted to my colleagues at the upstate New York VA Visit Network, Visit 2 Center for Integrated Health, developed this slide that really spells out not just levels of intensity, but just the shape of the triangle there, or the pyramid. It also is the numbers of patients, so that when you're looking at the really high need patients with severe mental disorders, you're looking at a very small number. It's really just the tip of the iceberg, and the reason we don't need to define all of their care based on those most needy patients. So here are the principles that really guide integrated care in the VA. And critically important is open or advanced access, meaning that it's not just, care is not just available in the same space, i.e. the primary care clinic, but is also available at the time that it's needed. We know that the longer people wait for mental health care, the less likely they are to partake of it once it arrives. So that's one of our basic principles. Open access, for those who aren't familiar, is really the term means it's just walk in, just come right in. Advanced access usually also refers to, at the very least, same-day appointments. But for many patients who may travel, they're seeing their primary care team at 9 o'clock in the morning. 3 o'clock in the afternoon may not be good enough. It's better than 3 weeks from now, but it may not be good enough. It's really problem-focused assessment and treatment. What is your goal for treatment? Why are you here? It may not be to get rid of my symptoms. It may be something completely different. And we know from a lot of the work in mental health recovery, acceptance and commitment therapy, and others, that the symptoms may not be the most important thing to focus on for most people. It's the on-site clinicians. We are present in primary care, providing a number of different functions. It can be their consultative advice during a team meeting. Here, why don't you try this with that patient? Or it may be, well, maybe I'll see that patient. Maybe he can come see me when he comes to see you. It's stepped care, which gets back to that primary, secondary, and tertiary. It assumes first that this is a problem that can be dealt with simply right here within primary care using brief interventions before going on to the more specialized mental health clinics for care that can't really be provided in an integrated care format. It's very much measurement based, just like any other health care. You get your blood sugar checked regularly if you have diabetes. You get your PHQ checked regularly if you have depression. When I was starting in psychiatry many years ago, I asked one of my supervisors, well, how do you measure, how do you know if people are getting better? I said, well, you can just feel it. And I think a lot of you probably, if they're mental health clinicians listening in today, have had the experience of you ask a patient, well, how are you doing? You get an answer that may not be based on anything other than how they're feeling today. But if you really give them some structured instruments, self-report instruments, so you don't have to sit there asking these questions, it takes no time of yours except to look at the results, you get a much cleaner a number, something that you can look to know whether things are improving or not. And often I've found in the clinic it would be fascinating. I'd ask a patient how they're doing. Yeah, I'm crummy, doc. I'm not doing well. And I said, oh, I was looking at your PHQ score here. It looks like it's gone down from like 19 to 15. Do you think anything's getting better? And they, well, actually, when you, yeah, I guess that's better. This is better, and so on. I've often heard of patients having their, getting printouts of their scores on the various tests, and having them posted on the refrigerator at home with the magnet, just like their blood sugar and their blood pressure. We include care management as I described it. And there's also part of care management is also referral management. Those patients who really need a higher level of care, there are various protocols that can help assure that they actually get there. So these are the two components: the care management, which I described. VA has a couple of versions of that based on impact, respect, and others, and then the co-located collaborative care, which is the clinician who's there in the clinic as part of the team, or it may be several clinicians. And so these two function in a very complementary way. Somebody might be seen by the co-located collaborative mental health provider and then be referred into the care management program for continued follow-up and go back and forth and do both, not sequentially, but both at the same time. We really focus primarily on these common mental health conditions because these are the ones that you're most likely to see appearing in primary care without a whole lot of complications. There's also a program in VA called Health Behavior Coordinators, and you'll hear me using archaic language when I talk about behavioral health versus mental health. And we usually use the term behavioral to talk more about some of those behaviorally sensitive conditions, things like smoking, obesity, stress management, and so on, as opposed to treating mental health diagnoses where we tend to still use the word mental health. We also have health promotion disease prevention program managers in the patient-aligned care team who help with just kind of overall overseeing all of the prevention efforts. As a healthcare system that keeps patients in it generally for many, many decades, we do have an advantage in that we can reap the benefits 30 years down the road of preventive care done now in a way that traditionally health insurance plans, where people often change plans every 3 to 5 years, they have not been able to reap the benefits of those. So the disease-specific care management, I mentioned the 20 years of trials. Here's what they do. And we're learning more and more things that can be done over the telephone. You can see the assessment, monitoring, behavioral activation, some problem solving. There's more and more stuff being delivered. Within VA, there's a group now working on some educational pieces for patients with trauma-related disorders. The two VA variations in care management are known as TIDES and VHL. I won't go into a lot of detail around that. Here again, it's a more detailed view of the co-located collaborative care providers. The evidence base for co-located collaborative care is nowhere near as extensive as it is for care management, but I can assure you it is developing rapidly. There's a couple of multi-center trials of brief treatments for PTSD in primary care. There have been an increasing number of trials of very brief CBT in primary care. We're working now to adapt problem-solving therapy that's been used in specialty mental health for primary care. So there's a lot going on, and the evidence base is really rising rapidly. And I think a lot of the concerns that many of my colleagues have had in mental health, that this is brief treatment, this is mental health light, this isn't the real stuff, I think we're developing more and more evidence every year to demonstrate that that's really not true. Here are the most common interventions being used now. Jen Funderburg, who some of you may know, who's in upstate New York at the Center for Integrated Healthcare in VA, had done one study looking at what are we actually doing. We also find that in the really well-developed programs, really taking care of 3/4 or so of mental illness right there in primary care. Which really kind of fits that old 80-20 model that people may be familiar with of 80% of problems are really not that complicated. One of the things this does is it really helps to shift. When you shift more of the care into these brief methods in primary care, you find that these secondary and tertiary levels of care suddenly develop capacity they didn't have before. It's been a remarkable finding that a couple of things happen. One is you're treating more of the patients within primary care. They're responding, and they don't have to go on to specialty care. The other is that the patients who are going on to specialty care are more likely to engage in care once they get there. So they're more likely to show up. They're more likely to engage, so you don't get all of those treatment dropouts that may be doing more harm than good. Here's some of the evidence base, and primarily focusing now on, there's some on non-VA studies, but also I've thrown in some VA studies as we gather more and more information. Certainly have demonstrated access and identification is just tremendous change. In most programs that have gone from no integrated care to integrated care, you find that their number of identified patients with mental disorders almost doubles. And even better than just identifying them is they're actually getting treatment. We're finding routinely that they are more likely to engage in mental health care. And that was true in non-VA studies as well as VA studies. And the quality of care is improved. If you start with care as usual in primary care without integrated care, and compare it to systems where they do have integrated care, the likelihood of guideline concordant treatment is higher, and patient satisfaction is quite high. And we're beginning, a lot of this, we're still at the point where on a large system basis we're often just using process measures, kind of looking at the process of care. We're beginning to look more and more at actual patient level outcomes, which are increasingly promising. So where do you start? This is one of the mistakes I once made. I was 20-something years ago when I was fairly new as a service chief. I wanted to start a supported employment program. So I made the mistake of going to the best one in the country, which was down in Bedford, Massachusetts. And it had been going since long before anybody had ever heard of supported employment. And it was a fabulous program. It was more of a compensated work therapy, but it was bridging into supported employment. And I came back, they were making stethoscopes for Littman. They were doing bookbinding for publishers. It was just really overwhelming. And you got to start where you are. Some programs have really started just with a complete redesign and got going, but you really have to start where you are. Where are you? Do you have space? Find space. When I was starting a clinic in Vermont, we borrowed the dirty linen room in primary care. You don't have that many dirty linens in primary care, and you certainly don't need a whole room for them. You find someplace. You got to understand what your reimbursement system is. Unfortunately, a lot of these programs do have to start with grant funding. But you find out what you can do. Some programs, some of the more successful ones that I have seen, started without special grant funding. They started by shifting their model of care, shifting their resources. Again, it's easier to do in a capitated reimbursement model. And where are you culturally and organizationally? What are the, one of my favorite quotes from organizational ethics was Organizational Ethics book by Robert Lyman Potter. There was a statement in there about organizational ethics is described as the intentional use of values to guide the decisions of a system. You really have to start with your beliefs as a system, as providers. What's important, and not to forget your patients. What do they want? Bring them into the discussion. What are they looking for? And you may find that you're not ready to start with a lot of integration. Maybe you're ready to start just by having an on-site triage person in primary care. Or maybe you're ready to go the whole 9 yards and go big. Whatever it is, you start with where you are, because if you start too big, and you won't be able to sustain it. Yeah, and as I already said, you really have to understand where your reimbursement sources are and how they see their future and what they're looking for. I'm going to conclude, and I think I will have left enough time for 10 minutes or so of questions, with the other side of this, where VA has indeed gone a slightly different, a somewhat different way than a lot of the rest of the world. And we know there's a lot of evidence that shows that if you put some general health resources, some primary care resources, whether it's a care manager or a mid-level provider in a community mental health center, that you get better primary care. Many of us kind of see the difficulties serious patients with serious mental illness have with navigating the healthcare system, not so much as anything intrinsic to the disorder or the patient, but really more about the system and how we're designed. And that maybe it's up to us to make primary care more easily able to handle patients with severe mental illness, the people who we know are not getting mental health care, who we know in the general population die about 20 to 25 years earlier than people without mental illness. In the VA, it's closer to 15, but it's still unacceptable. So we have three models for serious mental illness in the PAC. One is just the regular primary care, but really putting more emphasis on care coordination and building the relationships with specialty mental health services. Another is to have one teamlet that gets some extra training and reduced caseloads and gets more patients with serious mental illness than they otherwise would. Or then the other, which is more consistent with what's going on outside the VA, to bring some primary care into the specialized mental health program for the seriously mentally ill. For that latter group, one of the statement was developed with input from patients as well as staff. That really the goal of that approach is to transition patients eventually into regular primary care in some way. We know that it's very hard in a lot of systems, especially smaller places, to really deliver good, comprehensive, holistic primary care outside of a place that's already equipped to do that with clinical dietetics, clinical pharmacy, and so on. But it's not impossible. Many places are doing it successfully, but our goal is that for those who are, that the patients eventually go back into primary care. So I guess this is my bottom line when I think about it, is that we just have to remember that this is all about health care. It's not about primary care. It's not about mental health care. It's about health care, which, as I had shown in that very first slide, healthcare has influences beyond what healthcare system itself does, and we just have to pay respect to that. So I'll close there. This is contact information. I'm happy to have emails from anybody who wants to talk more. I'm happy to talk on the phone, whatever works for people. So I should be able to transition this back to Polly.
That's correct. Thanks, Dr. Pomerantz. Let's take a few minutes and open this up for questions. We do have one question. Dr. Pomerantz, a question that came in is, what is the rationale for not consolidating the VA and DOD systems to bring more efficiencies and bring quality, improved models, including mental health care, to active service members?
I think there's good rationale on both sides of that, and indeed there are some fully integrated clinics and health centers being developed. There's one up in North Chicago, what used to be the North Chicago VA and Great Lakes Naval Air Station. That's the only one of those that I have visited. I think that there are some issues on the other side too. Our missions are very different. The DoD talks a lot about the quadruple aim, with the fourth of the usual aims being combat readiness, while our fourth aim is more along the lines of community integration and functioning. Those are just two different communities with two different purposes. There's been a lot of work done on developing a lifetime electronic health record that combines both into one package. I think the jury is out on whether we are really establishing any cost efficiencies when we do this. It's being piloted in a number of sites, and I don't think we have the answers yet as to what makes the most sense.
Very good. Dr. Pomerantz, there's another question about the VA and the issue of managed behavioral health carve-outs. The question is, Why doesn't the VA speak out more clearly and unequivocally for the end of managed behavioral health carve-outs?
I'm trying to figure out how much trouble I get into by saying what I think. I think that a lot of us are really committed to being in the VA because we think that it is a system that can show what a healthcare that does not use a separate carve-out can be. I think that there are a lot of difficulties. I've never, I guess you could say that I used to work in that kind of system when I was in primary care. Somebody needed mental health care, behavioral care. I had to deal with, go through a lot of routines, deal with a separate organization, and so on. I think there are a lot of arguments that would say that you can be a lot more effective in healthcare by not doing a carve-out. Just very simple things like the sharing of information. I know that some of the FQHCs that have partnered with CMHCs to build medical homes have a lot of obstacles to the sharing of information that single systems don't have. I think that I can understand the sentiment of the question, and I am fully in agreement with the sentiment if I'm interpreting it correctly.
Thank you, Dr. Pomerantz. One last thing, a participant has mentioned that there is an integration toolkit available that the Massachusetts Patient-Centered Medical Home Institute or initiative has commissioned the development of an integration toolkit, and we will be passing out the link to that toolkit to all participants in today's webinar. We'd like to thank all of you for joining us today. I want to give one last opportunity for any more questions. It looks like we've worked through most that have been submitted. This webinar will be recorded and housed on both the CFHA website at www.cfha.net and also on the ARC Academy for Integration website. We'd like to thank you for joining us. We will have another webinar in November, and we'll be disseminating information about that sometime in the next couple of weeks. Again, thank you all.